So, anyone that's seen my presentation last time, sorry, this might be a wee bit boring, but it's the same person. So, a little bit about me, bit of an egomaniac, so I do like to talk about myself every now and then. I graduated in 2009 from Queen Margaret. I've done loads of training since then. Basically acupuncture, soft tissue mobs, joint mobs, cosmetic, wound healing, MSK, you name it. I was the only hospital ward podiatrist in NHS Lothian, dealing mainly with wounds, gangrene, all the fun stuff. I opened my clinic in Preston Pans in 2018. Preston Pans is like the greatest place on earth, not being you need to be coming up. East Lothian's beautiful. And we had a little battle there, in 1745, so we're quite famous. We now have a team of 4 full-time podiatrists and 1 part-time podiatrist. Currently in the process of hiring another full-time podiatrist. Thanks, Sasha, for convincing me to make it full-time instead of part-time. And we've got 2 admin support. So we've kind of grown arms, legs, and then about another full body since 2018, to be honest. Now, the patient here presented as a 38-year-old female. No medical complications. You know what I'm going to do? I'm going to hide you all because I don't want to see myself. There we go. So, no medical complications. After talking to her after last seeing the presentation, I sent a copy and she went, "You do realise that although I injured my foot and that caused the wound, it was the sciatica to start with." And I was like, "No, you didn't tell me that." So, yeah, that's why we've been trying sciatica on her. So, she is a very active lady. She's got a home gym. She goes to the gym herself. She exercises 3 or 4 hours a day. She basically hurt her foot previously due to the neuropathy caused by sciatica. As I said, she hadn't mentioned it was caused by sciatica. She just presented, and I've been seeing her for ages, and it never came up at any point, even asking her what caused it and things. Never twigged her to say, my back pain could have caused this. But still. So what happened was, on holiday, she decided to pick a bit of loose skin. It started bleeding, and as you do on holiday, you go to the beach, you go to the gym, you go to the pool, and this lovely thing happened. So we had quite a sloughy wound, lots of devitalized tissue around it. It wasn't too deep, but she'd been seeing the practice nurse, the GP, for about 6 weeks by the point I seen her. Nobody had got any resolution. It was actually getting worse and deteriorating continually. She'd been given antibiotics. The wound was dressed with a bit of gauze and tape. And basically no offloading or other support was given. NHS podiatry at the time, for whatever reason, just it didn't work for her. That's what I'll say. She had issues getting in and things. So she ended up at our door and basically begged us to try and fix her. So what we done, we started just with the wound healing. After about 3 weeks, much of the slough, dead tissue had receded quite nicely. A mixture of antibiotics, primarily honey dressings to start with, just to break things up, a bit of Actolite and Betaine foam with some offloading from semi-compressed felt. We then moved on to Aquacel, Betaine and offloading. I did put her in a Keraped at this point as well to offload the pressure and taking the area completely offloaded. So it seemed to be working pretty well. We then got the laser. I'd been speaking to Steve about a month before. We got to the point of saying we need the laser, and one of the big selling points is the fact we can use it on wounds. So after about 8 weeks, this is how it presented on the first week of using the laser. So as you can see, the slough's receded, the skin's looking a lot better. The wound was a lot better. There wasn't much depth to it, about 3-4 millimeters, to be honest. Really quite happy with it at that point, but it just was becoming a bit stagnant. So we started using the laser. As you can see, 3 weeks of laser, you've probably got, if I just flip back quickly, around about 1/3 the size, I would say. Certainly the depth was much improved as well. She is awkward with compliance. She will not stop going to the gym, so I had to come up with a whole new training regime for her, stopping her cardio, basically moving on to things such as weights and less foot pressure, which she was semi-receptive to. That's the best way to put it. After about 6 weeks, the wound had healed. So, we'd went through 8 weeks of conservative treatment. I say conservative treatment, hacking at something with a scalpel is not that conservative. So, about 8 weeks of wound treatment and dressings. We then got to 6 weeks of using the laser, and it had actually healed over. There is a sort of thin line of scar tissue in the area, which you would semi-expect with the depth and with the size of it, to be honest. It's getting a good vascular supply. There was no complications with any of those regards. So it was just a bit of a pain for her that we'd got stagnant, but 6 weeks of laser and it was all nice and healed. We have continued to keep her offloaded though. We managed to reduce to dressings just to semi-compressed felt. That comes with its own complications, but she's not very compliant with orthotics. She just doesn't like them very much. So I tend to find whether it's semi-compressed felt or something when she's in the gym, take it off, give it a good clean. We've came up with a good regime for her. By the February, I think we'd seen her in the October or November to begin with. This was the February, so we were pretty impressed. As you can see, still a bit of dry skin around in the area. For me, that's probably one of the complications of it being kind of covered for so long. But we were quite happy with how it was going. We had a little issue in the March. She decided to start just basically going to a lot of impact at the gym again, a lot of treadmills and things. It was a small breakdown, nothing much. We managed to get that tidied up within 2 weeks. But as I say, we've had to just adapt her protocols, her training, and it's more compliance now. She realised the need for the compliance. Not everyone likes to listen to me, but when you do listen to me, you tend to learn something. So she's trying to listen. So we got to about August. No ulcers, no breakdowns for about 6 months. She's delighted. We've got orthotics, which she can tolerate, which she can use. She really enjoys her new gym setup, particularly the weights. She's very happy with all of these issues, which is good. That was her on Monday. You will forgive me, I didn't think to take a photo until after I'd sprayed the foot with Clinicept, but yeah, it looks pretty good. As you can see in the sort of middle area, there is still that sort of scar tissue area. I don't think we're going to get much away from that now. It has reduced, it hasn't broke down. We are just monitoring it, just gentle debridement where needed, just weekly monitoring. But that's her point. I've said I would be happy to see her every 2-3 weeks, maybe even a month. But she's very happy to see us weekly. I think that little emotional crutch she still needs, which doesn't bother me. We all need that at some point. It's quite nice to have somebody there supporting you. So we have moved on to now trying to actually treat a little bit of the sciatica neuropathy. Now, after chatting to Paul, who is one of the ASA experts, he has I think he does pretty much everything with the laser, does the training as well. He is excellent fountain of knowledge. So Paul was telling me about brachial neuralgia. That's one of the settings for, well, brachial nerve, obviously, sort of more neck and shoulder area. He said using that around the lateral ankle works pretty effectively at re-stimulating. So what we done was we have been using our lovely patient to try and help with her sciatica and to re-stimulate a bit of the neuropathy. So what we've been doing is generally using the Charlie head, the autonomous head, because I'm quite lazy. It does save you quite a lot of time in clinic if you do end up getting a laser. A Charlie head is fantastic resource. So we have been using that on the lateral aspect, generally just below the lateral malleoli, and we've been doing it about 3 inches above as well, just to catch up the leg rather than above, up the leg, to try and catch as much of that stimulation of the nerves as we can. She's actually been getting feeling back in the area, which she had basically lost for a year plus before the wound. We started off doing sciatica. I didn't take photos because it's an awkward area to take photos of with a young lady, the lower back, bum and things like that. So I thought, you know what, let's just show the ankle. And to be honest, she didn't react too well to sciatica, probably because she wasn't experiencing sciatic pain at that point. We've had a lot of results with sciatic pain. For me, it's one of the issues with lower limb. A lot of sciatic pain can be caused through lower limb abnormalities. So taking them out of pain can allow you to then progress onwards. I very much advocate the lower back as part of the podiatry remit. I can treat that as part of my medical acupuncture, but you know, if you're talking about gait issues and not looking at the lower back, I think you're probably doing yourself a little disservice. So for me, we've had good results with sciatica. With our patient here with the neuropathy, we've managed to stimulate some of that feeling again, as I say. Every week when she's in, we just do that. It's getting a little bit better every week as we go on. We've not been doing it for particularly long, but she's feeling more, which is good. So, what's happened with that? There we go. As I say, not the best compliance with orthotics, but we have convinced that wear a Cedus memory foam insert in our gym shoes. They are excellent for offloading, very reboundable, lots of good material. I really like them. We have now got a skincare routine of Flexitol Platinum and Bio Oil just to keep the area in good condition. We are still using the laser to try and help the scar tissue. It's certainly preventing any issues. The other week she was feeling a little bit of discomfort, so we used the bursitis setting just in case there was a bursa, a little bit of fluid in the area, and the next week she was perfectly fine. We've also been using the laser just as an experiment with her neuropathy. As I said, she's now got feeling in that for the first time. Certainly the sciatica for her hasn't been an issue since, but with other people with sciatica, we've had very good results, including one chap who literally couldn't work for about a month before he came in. 2 sessions of the laser with sciatica, and he's away back to work as a delivery driver. So he's not exactly in a sedentary job. He's very active, carrying heavy items. Very worthwhile trying out the sciatica setting. It does work well. I like mixing in the brachial neuralgia every now and then, and it does a good job. Our patient in this study is still coming in weekly for laser, as I say, just a checkup, but very happy with the results. She's delighted. We're delighted. It's looking pretty positive, to be honest. In our clinic, we use the laser continually, so thank you for letting us have 2 at the minute, Steve. Basically, it's never stopped. From the time it gets turned on at 8:30 in the morning, it doesn't get turned off. I'm not joking with that. We had a new start in August. That's scary saying that she only started in August and we're hiring again, but yep, we are. I think it was like her 5th day or something like that. She literally seen back-to-back lasers up until lunchtime. It's an amazing bit of kit, and we use it for everything from MSK injuries. We use it on wounds. We've been trialing it on fungal nails. I won't step too much on that because Sasha's got to talk. But we've been getting good results with that as well. So yeah, we've added the autonomous head, the Charlie head. That's fantastic for areas such as knees, hips, plantar fascia, anything slightly larger, the Achilles. We really enjoy it. The M6 is a good bit of kit. Takes a little bit more getting used to, but I quite like that you can turn it on and go away and make adaptations to your orthotics. So M6 is very good if you sort of multitask in clinic quite a lot. We've reduced healing after nail surgery, wounds. Generally, things are about half. Most things for wounds, particularly post-nail surgery, are down to about 4 or 5 weeks instead of 6 to 8. So I'm very happy with that. So we love our lasers. That's the talking point of our clinic, to be honest. Hopefully, that's beneficial to you.
Very brilliant. Thank you, Adam. A couple of quick questions, if I may, that have come in from the floor. When you were treating the wound, was that once or more per week with the laser?
We were doing twice a week when it was at its worst. So weekly wound dressings are fine, because I've done a lot of the worst wounds on wards and things like that. I always prefer, if you can, twice weekly, just to prevent the bacterial buildup and try and keep infections under control. So if I can get somebody in twice a week, I will get somebody in twice a week. We used the laser at both appointments. We did only have the handpiece at that point, and it still worked magic. You can see the results, It's a great bit of kit. So we have been very lucky with that. When we got the laser, it's made such a dramatic difference to her.
Okay, brilliant. Thank you. I'll come back to you at the end with a couple more questions, but just in case you don't know it offhand, I'll ask you this, but you can answer it later for us in the Q&A. The protocols that we used are on the laser for the wound healing. And then another question is, was there any other interventions? And I think that was right when you were talking about the wound in particular. So I'll come back to you on those, if I may, Adam, but you can have a little think about those to come back to us in the Q&A, if you don't mind. Is that okay?
Fine, Barry.
But otherwise, up to that point, otherwise, that was brilliant. Thank you ever so much for getting us going there, Adam. There are questions coming in as I'm speaking. I'm conscious of the time, so we're going to keep moving. Did warn you guys that we got a lot of information to share with you today. So thank you, Adam. That's great. So now we're going to move on to Kirsten. We're going to welcome Kirsten Sinclair of Orkney Podiatry of Haig Clinic in Orkney, conveniently enough.
Yeah, it's Huga, Steve.
You what, sorry?
It's Huga.
Huga? Beg your pardon.
I'll forgive you.
Okay. I'm glad I got Orkney correctly. I normally get caught out on the medical words. I don't normally get caught out on names of places. You've caught me out on everything. So Huga Clinic in Orkney. Kirsten is one of our early adopters on the laser within podiatry and has seen some great results for her patients. So good, she has since sold her Shockwave. I said the S word. I've got it out of the way quite early on. Like Adam, Kirsten has previously presented for us. Last month, she joined us on the webinar entitled Adding Value to Your Practice, One Pod's Perspective. And I should say, actually, if you want to, if you'd like to see those presentations that Adam and Kirsten have done previously for us, just let me know on chat and I'll make sure I get those sent to you. So they're all available. As I say, an early adopter with the laser, with the M3 unit, but Kirsten is currently trialing the Ultra Head at the moment. And today, Kirsten is going to share a case of heel pain, I believe. So over to you, Kirsten.
Thank you. So I am just going to jump straight into my presentation. I've chosen heel pain as the topic to speak about because I know that podiatrists see this all the time in clinic. So hopefully it'll be quite useful to everybody. So the case that I have chosen to speak about was a man who came in earlier on this year, a male in his late 50s, good general health, no problems except for the heel pain that he developed. He is a very active guy. He enjoys walking with his dogs. I think that's kind of one of the things probably for his mental health as much as his physical health. He liked to do that. He also does cycling and canoeing. He works with the RNLI. He has a job that takes him all over the UK, and this was another reason that I've chosen to speak about this patient, because he was slightly more complicated in that we never quite knew how long he was going to be home for. He was on call, so he could get called up the next day. He might have to leave for 2 or 3 weeks. We couldn't really guarantee any specific treatment protocol. So we needed something that was kind of going to hit hard and fast, if you like. So he came into the clinic complaining of a 4-month history of heel pain on his right foot. He'd previously had left-sided heel pain, which had resolved itself after a couple of months, but this wasn't getting any better. It was starting to extend into his medial arch as well. He described the typical plantar fascia symptoms of first step pain that eased once he got going. He described the pain as a throbbing pain, and the day that he actually came into the clinic, he said that it had been throbbing all day, so that pain hadn't eased at all that day. So we kind of needed to do something because this wasn't getting better for him. He'd actually started walking on his forefoot to relieve the pain on his heel, which obviously wasn't ideal, setting yourself up for compensatory problems then. And he'd also had to stop walking the dogs and things like that, so it really was affecting his quality of life. He had previously spoken to a GP, I think just a phone call because of lockdown, who had given him some exercises, and he'd done the typical Googling plantar fasciitis, so he'd found some exercises through that as well, which he'd been doing, but he didn't really know exactly what he was doing with it or why he was doing those exercises. They hadn't really helped him that much. He's also been kind of doing a bit of the rolling of a ball under his foot. He'd done some stretches with a band, again with no real protocol to that. He had bought himself some cushioning insoles to put in his shoes, which he felt helped initially, but that effect wore off quite quickly. And he'd even tried a TENS machine. He was so desperate to relieve his pain that he managed to get his hands on a TENS machine, which didn't really do much for him either. So not to go too deep into it, but we did the assessment, kind of ruled out at that point differential diagnosis, things like Baxter's, thought that yes, this was indeed plantar fasciitis. He had the pain on palpation of the medial tubercle and the first step pain and all the rest of it. So we went with the assumption that this was plantar fasciitis that we were treating. In an ideal world, we could have done a little bit more investigation into that, maybe an ultrasound, but we didn't have that. So we just had to go with what we had, which was my assessment. So due to the nature of this patient's job, we needed something that would hopefully give quick results, would be easily managed, could adapt to his job. If anybody's heard me speaking about my use of the laser before, you'll know that I don't necessarily stick with the suggested protocol, which often is 3 treatments the first week, 2 treatments the second week, and then 1 treatment the third week. I tend to do 1 30-minute treatment per week for up to 4 weeks, and that works really well for us. So that's the kind of protocol that we looked at for this patient. I had suggested the laser to him because with the hope that it would give him immediate relief, or at least, you know, get him on his way to getting better again. And he was really keen for that because he wanted the problem sorted. I also explained to him that laser is not a standalone treatment and we need to throw some other things in there as well. And he was quite happy with all that. I always describe the extra treatments, so I'll come back to that at the end, but I call it my patient toolkit. Like I say, I'll come back to that. So we did the laser treatment in his first session, and I used for that, I always do a scan phase, I do a pathology phase, and I do trigger points as well. So for this patient, I did the scan phase, initially the foot and ankle scan phase over the plantar heel into the medial arch where he was feeling the pain, and we did kind of around medial, lateral, posterior aspects of the heel as well, and slightly up the calf too. I then did the ankle tendonitis pathology phase, and I focused that on the areas of pain that he was getting, and then we followed that up with trigger points, which we did at 10 hertz, 50% and for 20 seconds, and again did those on the areas of pain, into the medial arch and up the calf, where we could palpate those trigger points. And he felt immediate relief after doing that, which was great. He had been the type of patient where you palpated the area of pain and then peeled him off the ceiling because it was so acutely sore. So after we'd done that treatment, I could palpate it and he felt immediately better. I hadn't been able to assess him when he was weight bearing because he couldn't put his foot on the floor, couldn't put his heel down. But then after we'd done the laser, he was standing with his foot flat on the floor, and he was absolutely delighted, and so was I. It was one of those, this is why I do this job type moments. You know, he was so pleased. But before he left, I also gave him strapping to do. So I usually just give people the heel pain strapping because it's easy to apply. I think it's much easier for patients to do themselves than low dye strapping, and so sent him away with that to do initially. I also gave him a pair of Slimflex Comfort full length orthotics because the cushioning ones that he bought for himself were akin to putting like a slab of jelly in his shoe. You know, they were really unstable, not much support, so it just kind of upgraded his orthotics. And I also gave him an exercise program. So the exercises that I gave him were basically the same as the exercises that he had been given from his GP and online, but I gave him more of a protocol for it. So I got him to do heel raises with the rolled up towel under his toes. He did 12 of those 3 times. He was doing the short foot exercise, and I got him to do the ball rolling as well, kind of 2 to 3 minutes in the morning before he got up to reduce his first step pain. And again, at the end of the day, just to ease any pain that he'd built up during the day. So he went away and did that as well. And going back to the toolkit, I always say to people, you know, if you've got the orthotics, you've got the exercises, you've got the taping, then that's your toolkit, and you can pull things out of your toolkit as and when you need it. And the laser will speed up that process, you know, it'll speed up that healing and that pain relief process. So for me, that's important because it gives the patient back some control over their own treatment as well. They're not just relying on me and coming into me for the laser. They've got these things that they can do for themselves as well. After doing his first laser treatment, as we half expected, he got called away, and he was away for 2 weeks, so I wasn't able to follow him up in that time. But he came back to me 2 weeks later, and absolutely delighted. He'd had a huge improvement. He just had some residual pain and discomfort. So we just did a repeat of the laser treatment that we had done previously, just exactly the same parameters, same settings. And that was the only thing we changed. Everything else stayed the same. I did a phone review 3 weeks later, and he was completely asymptomatic. His pain had gone. He was back to walking his dogs, and quite delighted. So yeah, I chose this case to demonstrate the value in laser as an adjunct therapy, aside to that patient toolkit and the things that you give them, and as a method of speeding up healing times. Particularly useful in patients who really need that quick resolution, and who can't necessarily commit to long-term coming back and forward. You know, it's just good for giving that hard and fast results. Yeah, that was it. No slides from me, sorry.
No, that's fine. It's great to hear your case there. It's great to hear that, as you say, share those good moments with us. And as I say, it's always pleasing when you get those kind of results, isn't it? So
Yeah.
That's great. I'm just checking if I've got any questions coming in. Somebody's asking, did you stick to the ACER protocol? Did you stick to the laser protocol on that?
So if by protocol you mean the settings that are preset in the machine,
yeah.
I did for everything except the trigger points, which at that time I was doing the 10 hertz, the 20 seconds and the 50%. Now, after kind of learning that there's a slightly better way of doing that, I do trigger points at 10 hertz, 23 seconds, and anything between 25 to 75% depending on the patient and their history. Yeah.
And I get, I would say, would you say that's one of the, bit of a loaded question here, would you say that's one of the benefits of the machine? Obviously the protocols are there, the presets are there for pretty much most things.
Yeah.
But that opportunity to override where you believe you can or need to.
Yeah, I very rarely stray from the presets, to be honest.
Right.
Sometimes I do, depending on how the patient's responding. If they're, if I feel I could get more from it, then I might adjust the settings a little. But generally, I stick with the presets. I might not follow exactly where the machine tells me to use, for the pathology phase. There's certain points that the machine tells you to hold the handset on. I might vary from that depending on where the patient's areas of pain are, but as far as the actual figures, tend to stick pretty close to what's in there already.
Brilliant. That's good to know. Thank you. Thanks ever so much, Kirsten. That was great. Okay, I've got no immediate questions coming in, but may well speak to you again in the Q&A in a little while, should any questions come in the meantime. So thank you ever so much. So we are now going to move to our third. I'm just going to unmute India. I think are you unmuted there, India?
Yes, I believe so.
Hi, India. How are you? You okay?
Hello, good, thank you. Yes.
You've had a very busy morning, and so everybody in the audience knows, India literally tuned in with us literally a minute to 12 o'clock, having just finished her morning clinic. So we're so grateful to India to give up her time and share with us a case study. So India Scopan, I believe, Scopan, I said that.
Scopana, doesn't matter.
Of Edinburgh Podiatry, having taken on the laser in July. Again, you've been delighted with the outcomes achieved for your patients. And as I say, despite a very busy morning, you're still giving up. We're so grateful to you giving up your time and joining us here today. And you are going to share a case of piriformis bursitis, I believe.
Yes.
Over to you.
So thank you. So I'm just going to jump right into it because I have another patient coming in at 1 and I'm still mindful that Sasha still has to talk as well. So basically, I had a lady come in. She's 63 years of age. She is historically a dancer, a ballerina in fact. And when she was dancing, she sustained a lot of injuries. And for the last 15 years, she has had hip pain. So she came into the clinic not because of the hip pain, but because she thought she had plantar fasciitis and she wanted to see if her current orthotics needed updated. So luckily by that time I already had the laser, but not in Edinburgh Clinic, in my other clinic, in Midlothian Clinic. So I said to her, look, I have this very cool laser. If you want to travel to Dalkeith, I'm going to laser you. And she was like, oh, do you think it might help as well my hip? I was like, what's wrong with your hip? So she basically explained to me that for 15 years she's been in pain, and over a year ago she has been diagnosed with piriformis bursitis. For that, she had a steroid injection which worked brilliantly. And then 6 months later, the pain was back, so she went and got another steroid injection. But unfortunately, following her second steroid injection, she ended up in hospital with heart palpitations. She just couldn't cope with it. So she's decided that she cannot have steroid injections, and she kept looking for alternatives. So when I mentioned the laser and she asked me, can you do my hip? I was like, yeah, of course, we'll just do everything. We'll do everything. So because I was just starting out with the laser, I was quite cautious with the settings I was using. I didn't want to be too adventurous, so I sort of took it slow. I proposed to her that we're going to do 3 treatments in week 1, 3 treatments in week 2, and 1 in week 3. So on her first treatment that we did on 21st of September, I just did plantar fasciitis setting on her heel and hip pain general scan phase on her hip. Super cautious, as you can hear. I learn from my mistakes as I go on. But anyway, she came back for her second treatment and she said pain improved 50% in the hip and 30% in the heel area. So what I did afterwards, I thought, right, we kind of need to then work on this a little bit more. So following that, I used bursitis setting for the hip. I also used pain and inflammation. And then we just did general pain for the plantar fasciitis and a plantar fascia setting. And then that was on the 23rd of September. So she returned then back again on 25th of September, saying that the hip has improved. So 80% improvement in the hip. She was absolutely thrilled. And just to mention as well, one of the things I kind of told her to do is not to do her general activity. So she has a dog and she walks 10 miles a day with her dog. So I said to her, let's just keep it to a minimum whilst we go through this. So on the 29th of September, she came back again after her laser treatment and she said that her hip has improved 100%. But she didn't listen to me and she continued with her activity levels, continued with the dog. And I was like, well, fantastic. So that was her pain-free, basically from 21st of September to 29th of September. So I think that result, obviously, for myself and the patient was absolutely amazing. So going on after that, we continued treating her plantar fasciitis, which I'm not going to talk too much about, but every time she came back, she just said her hip was fine, her hip was fine, her hip was fine. So yeah, hip was basically pain-free after the 3 treatment sessions. And I'm just thinking, would have I done the bursitis at the first one? Would have that been quicker? But I think it doesn't really matter because she's been in pain for 15 years. And after 3 sessions of laser, she has 100% improvement in her hip.
That's brilliant. As you say, that's a result, isn't it? So people, they have to have that, you know, you could have got to it sooner, then maybe, but you got to it soon enough. So
yeah, exactly. And I mean, she's absolutely thrilled. She doesn't understand why other people don't use the laser. She doesn't understand why it's not on NHS and why have we not heard about it before, basically. So I definitely have a fan for the laser, and she's so happy and spreading the word as well.
brilliant, thank you. Now you mentioned the 3-2-1. That do you typically follow that kind of treatment timings? Is that what you do most of the time? Is that what would you say?
No, not at all. And yes, so it depends which clinic I am in, because in Edinburgh I'm only 2 days a week, so that wouldn't be possible anyways. But so in Edinburgh I would never do the 3-2-1 just because I can't. So I would get people to come back in maybe weekly. In fact, I have people coming in Edinburgh Clinic weekly to get their treatment done, and all of them are pain-free pretty much after 3-4 sessions. Just need to sort of apply maybe more or different settings and target areas better. But I think that all comes with experience, because at first I was like, no, I don't want to cause the rebound effect. So I was like, oh, just baby steps. But now I'm just like, yeah, let's just do it.
Brilliant. Got the confidence of you.
Yeah, absolutely.
That's brilliant. No, that's great. Thanks ever so much. Yeah, you know, I mean, it'd be great if it was in the NHS, wouldn't it? We haven't approached the NHS yet. The reason we haven't is I'm hoping to retire in 18 years, so I haven't got enough time to get it into the NHS. I'm not going to waste my time. Maybe my son can take that on. That's
yeah.
He's got time on his side. Anyway, thank you, Andy. Really, really grateful. I can't thank you enough, given the circumstances of you, fitting us in today. I hope you've found some time to grab a bit of lunch, or at least a cup of tea and a biscuit.
I did indeed. Yes, thank you.
So stick around for as long as you can.
Yeah.
I'll say a big thank you to now anyway, in case we don't see you at the end.
Mm-hmm.
Thank you ever so much. I've got one quick question from Tim, actually.
Yeah.
This is from Tim Vasey-Smith. Hi, Tim. Nice to see you. Can I ask what outcome measures you guys are using to monitor improvement with each session? Or maybe I thought I was maybe directed yourself. Maybe we can keep that to the end and have a general chat for everybody. So question for all of you at the end. Can I ask what outcome measures you guys are using to monitor improvements with each session? Alrighty, so that's a question for later on. Thank you, India. Really, really grateful. Right, okay. Let's keep going. What's the time? 1:45. This is great. We're doing great. Lots of information already. I'm now going to introduce you to Sasha. Is Sasha there? Can I find?
Hi, yes.
You're there. Hi, Sasha. So everybody, this is Sasha Cameron of Banff Podiatry and quite recently Bucky Podiatry. Congratulations on that, Sasha.
Thanks.
She's Sasha is qualified 2 years ago and just opened up her second clinic. So I don't know what's kept her. So I don't know what's holding her up there, but no, great stuff. Congratulations, Sasha, and seeing the pictures on social media and so forth, all looks great. So well done. So, and Sasha added the laser to her practice earlier in the year in June. And not only loving the uses of the laser, she's been pushing the boundaries of its uses. So we're going to move on to that with Sasha in a moment, where Sasha is going to be sharing a case of fungal nail with us. Again, so grateful to Sasha finding the time in this busy time for you. So over to you. You've got some slides you're going to share with us, I believe.
Yep, so I'll just do a screen share just now. 1 second. Can you see that okay, yeah?
I can indeed.
Okay, cool. So yes, we got the laser in June, so just really in the middle of lockdown. We use it every day. It's added to our clinical toolkit quite well, and we use it for a variety of things and to a varied demographic as well. So our typical MSK appointments, we have our physiotherapists using it and loving it as well. We also use it in things like arthritis, edema, wound healing, post-nail surgery, kind of similar to what Adam was saying. It's always generating more income for the clinic, but what we want to do is try and increase that revenue stream coming in. So I'm always trying to look to see how we can incorporate that into different treatments. I'm sure most podiatrists are the same, that onychomycosis is quite a common complaint coming into the clinic. So we started thinking, how could we incorporate the laser into this treatment? So like many other podiatry clinics, we have various sort of treatments that we offer for onychomycosis. And I would say our sort of main clinic-based treatment option at the moment is we are doing fenestration. So that's drilling micro holes into the nail plate and then asking the patient to use a product called Clinicept twice a day, and then returning every 4 to 6 weeks for further review. So if I just talk about Clinicept for a minute, Clinicept is a hypochlorous solution. It's a new product in podiatry and various other professions like dentistry and the aesthetics professions as well. But if anybody follows Ivan Bristow, he had wrote a really good blog about it recently, and it was titled Goodbye Chlorhexidine. So he kind of marketed Clinicept, well, he talked about Clinicept being a breakthrough product for podiatrists, and I totally agree with that. I use it for various clinical uses. But anyway, so it's a hypochlorous solution. And for the purposes of this, it has strong antimicrobial activity, in particular rapid fungicidal properties. Again, Bristol, just make another reference to him, in his blog, he had taken socks which were contaminated with fungal spores, and he had placed them in a bag with soaked in Clinicept overnight. And what he found was, in this little experiment, there was 99% reduction of fungal spores in the socks. So it really is quite an interesting fungicide to use alongside nail fenestration. Also, it's non-toxic. So if you consider the science behind hypochlorous solution, our own neutrophils in our body release hypochlorous acid. And basically that destroys pathogens, for example, if they're arriving at an infection site. So Clinicept has basically harnessed that science to create a product that's non-toxic, it's non-irritant, it's not flammable, which is always good, and it works within a pH range of, I think, 5.2 to 5.8, and our skin pH range is 5.5. So the likelihood for irritation in that product is very minimal, and it also minimizes the allergen risk there as well. So hypochlorous acid in wound healing, for example, it's not a new thing. I mean, there's been papers since the 80s about this, but Clinicept gave it a sort of rejuvenation. There are other hypochlorous solutions on the market, but Clinisept has the highest purity. I think it's over 90% hypochlorous acid. So it's definitely a good product that we've been using in treating neomycosis so far. Okay, so there's various other lasers that have been marketed for use in mycosis, so neofungus. And again, Ivan Bristow did a paper on this in 2014 doing a review of this. And he basically said that more evidence is needed to see if this is a viable treatment option in treating neomycosis. So, I mean, there's one that's maybe more a mainstream laser treatment. And if we look at that one in particular, it's got a wavelength of around 405 nanometers and 635 nanometers. And they advertise the fact that basically it destroys the fungal pathogen. And the 635 nanometers apparently enhances the function of the neutrophils and the macrophages in further degrading the fungal pathogen. So if we just sort of strip that back a minute, if we think about the laser that we have, it's way more powerful than that. The nanometers are 808 and 904. So potentially that could be destroying the fungal cell. And then if you consider Clinisept, it's also enhancing that neutrophil, well, it already harnesses that neutrophil function. So if you combine potentially the laser and the Clinisept, it could be a really good treatment option. But as always, more information is needed. Another kind of sideline that I thought of that's not really been touched upon was that laser actually increases blood flow to an area. So if you think about the predisposing factors often for neomycosis, for example, devitalized skin or diminished circulation, using a laser might help to accelerate healthy nail growth, which could be of benefit there. That's taken aside the fact that there's no matrix involvement. Okay, other benefits that I thought it could be is that it's painless. The laser doesn't cause any heat buildup. It's totally comfortable for the patient. Potentially, it could be a benefit for people who can't or won't take oral medication like terbinafine, or for people that have an allergy risk. It's kind of discounting that. So, ESA did a research paper recently in Italy looking at the reduction in viability of fungal cells using laser alone. So their parameters they had used was 200 joules, 1500 hertz, and a 5-minute duration at 100% intensity. I think, if I'm right, the parameters they used was doing a treatment, having a 1 hour gap, and then repeating that treatment again, and then repeating after 24 hours, but they kind of varied those parameters. They had concluded that overall there was a tendency to induce a decrease of proliferation, and I think their top line figure was 34%. They had also noted there was no inflammatory response there. So that's just looking at the laser alone, which was quite interesting, I thought. So I thought how I could take this into my clinic and make it more viable or feasible for my diary. So I copied their settings. So that's 1500 hertz, 200 joules, 100% intensity at 5 minutes per nail. If you're fancy like Adam and you have the ultra head, the Charlie head, you could obviously treat multiple nails at one time, but I have a handheld, so it was just 5 minutes per nail. And then I chose to do 3 sessions in 1 week, just to have like a short intensive burst of the laser, and then reviewing that at 4 weeks. And in that initial appointment, we were also fenestrating the nail as usual, so drilling the micro holes, and then sending the patient away with Clinisept to apply twice daily. So this is the case study that I did this on. So this lady was 42 years old, no medication, no significant medical history. We had done the 5-minute fungus dermatophyte presence test, which was positive. I think this was following a nail trauma. So this was on the 29th of July. And if we look at it 4 weeks later, the picture on the left, again, you can see there's no matrix involvement there, but the picture on the left is 4 weeks growth. So that's quite a lot of growth in that time. And you can see the line of fenestrated holes of the line of infection. And then if you look at the picture on the right, this was taken mid-September. So overall, a period of about 8 or 9 weeks, and you can see how healthy that nail looks now. So normally, just with fenestration and Clinicept alone, it would take, I would say, much longer than this. So this appeared to sort of accelerate the results using the laser as well. So then I got in touch with Ross at Clinicept and also Steve, and just sent them my findings. And then I rolled it out to, I think there was 10 people currently undergoing the trial in my clinic for this, and just playing about with different parameters. I've just started these in the last few weeks, so I don't really have many pictures to share, but this is one recently. So this was about 3 or 4 weeks ago. So the top right picture, you can see that her right first and her right fourth nail have mycotic involvement. We fenestrated the nail, did the laser, and this was just, I think it was last week, she sent me these pictures. So the left-hand side, you can see that that actually looks to be improved so far to me on the left first and, sorry, the right first and the right fourth. So far, I would say in summary, the early results are interesting. I'd like to expand the trial more and maybe try different parameters, but also try to find a balance between what's effective for the patient, managing their expectations, and also what's viable for a busy sort of clinic caseload. Yeah, that's me. Hopefully my internet.
Let me unmute. Thank you, Sasha. That was great. Thank you for sharing that with us. I mean, this is a really interesting point for us at Celtic with ACER, with the laser. This is really interesting for us. So thank you, Sasha, for sharing this. Because I mean, we know that with the ACER laser, we know that it works on fungal nail. The kind of drawback, if you will, why we haven't pushed it so much on the fungal nail, and we really do promote this as an MSK modality, is the timings of treatment doesn't fit in greatly with a typical practice. So it's been great that you've kind of, you know, found maybe a workaround, if you will. And I know Adam's done some, has been using it quite successfully on fungal nail too, without the Clinicept, just with the laser. And you know, do you want to jump in, Adam, and tell us what your typical protocol is when treating?
Yeah, basically we're trying to aim the 200 joules as well. We have done some matrix involvement. They're just starting to come back. You know, we're sort of maybe 3 months down the line of trying a few of them. It is easier with the autonomous head because you can basically put that over the whole foot, really, and that'll work them all. We have tried it with some people coming in an hour after the first session, and we've tried it with some people just coming in daily for, I think it's 5 days, and then some people 3 days. We're getting good results. We've always been looking to get the positive dermatophyte test first, just so we're not wasting anyone's time, but it looks promising, so I'm happy with that so far. It's early days, baby steps.
No, it's great, and that, you know, and just hearing the success that Sasha's seeing and yourself is really encouraging. Because as I say, we don't promote it as a nail fungal treatment. There are lasers out there that do, and that is all they do. This is very much an MSK and wound healing, as we've seen from Adam. So already pretty versatile. And if we can come up with good workarounds and we are doing some case studies. We've got a group of podiatrists doing some case studies with us where we're going to be trying slightly different parameters, the same protocols that ACER are recommending, the 1500 hertz to 200 joules, but the timings of the treatment to make it practical within a typical busy practice. But actually, Adam, you said something to me quite recently where you know, really that's for the practitioner and the patient to decide, you know, how often they can come in for treatment, really, isn't it? Rather than
It's quite easy now with so many people, you know, sitting at home watching Netflix. A lot of them aren't that bothered if they go for a coffee across the road or go to Greg's. We're very lucky. We've got about 3 bakeries and 14 takeaways within walking distance.
So
Seriously,
keep yourself busy in between treatments. Yeah.
Oh. Yeah. So we're quite lucky to be able to get people back.
Yeah, no, but you know, and back to Sasha, I think it's great that you've got two modalities, if you will. You've got a treatment, an ointment, if you will, and you've got the laser modality, and you combine the two, you're seeing quicker results. That allows your patient to be more compliant. I've picked up on Kirsten and Adam's and India's presentation that you guys struggle with, or one of your biggest problems is getting your patients to be compliant. So if this allows the patients to get away with something, then that's got to be a good thing, hasn't it? So I think from that point of view, the combining the two allows better compliance for your patients, allows a better timing for the treatment to take place, to working in your busy clinics, and I think clearly combining the two is showing some great results sooner. So that's great to hear, and I think all credit to you, Sasha, for you know, thinking outside the box, pushing the boundaries and seeing what if, really, you know. So that's great. So thank you. Okay. Anyone got anything else to add? Kirsten, do you have anything to add on that in particular? We've lost India. India's gone to her afternoon clinic. So I'm okay to stick around if you guys are. I suspect 1 or 2 people have got to get back to work, but let's take 1 or 2, still got 1 or 2 questions. So let's fire those at you that came in a bit earlier. Adam, coming back to you, the question, were there any other interventions, was for the gentleman back to work after 2 weeks.
Yep.
Can you elaborate on that for us, please?
I am a big believer in rehab. With most people, you can find a reason to chuck an orthotic in the shoe, but I just didn't bother. I felt it was more weak glutes, quite stiff in the diaphragm and the pelvic floor, not allowing that sort of movement through the hip, and quite poor loading, to be honest. So when his foot was hitting the ground, I felt more the upper leg just wasn't supporting, his lower leg was doing quite a lot. So we did give him a full rehab plan, more on that, but he was in that much pain, he couldn't do much of the rehab. It was the laser that actually got him out of pain to start with. So that's what we use laser for a lot for our MSK. There's no point in suggesting to people, by the way, can you do 10 exercises? Can you go and do all of these things if they can't physically do it without being in agony? They're not going to. So for us, we use the laser really as a first modality, right? Let's reduce the pain, figure out what the problems are, and then treat the problems. So yeah, that was us for that one. Bar a bit of rehab, he's not had anything outstanding.
Brilliant. And whilst I've got you then, so on specifically to the wound, can you recall what protocols were used?
Yeah, it's very easy. It's got a lovely little button that says wound healing. I don't really need to mess on too much with that. I think it comes out at 1500 joules. It's 100% intensity. And what you do for a wound is, let's say it's here, and it's maybe about, call it 6 centimeters sort of squared. You do about 3 centimeters around the diameter as well. So always cover an area around it just to stimulate that local area. I bought a very handy, I think it's for arts and crafts, a wipeable plastic thing off Amazon for centimeters squared. I'm not doing maths if I don't have to. Let's work clever here, you know. So you cover that. That'll tell you exactly what you're doing, and just make sure you cover that sort of extra 3 centimeters around it. And from there, that'll tell us what to do. You power it down. The automatic's 100 centimeters, so you don't want that for something which is maybe about 4 or 5. You then scale it down to your sort of 4 or 5 plus your 3, and that'll bring the time down as you're doing that as well. It's very point click, simple. I can do it. It's not that hard.
Brilliant. Good. Okay. We had a question earlier from Tim, so to all of you, to Sasha, Kirsten and Adam, any outcome measures, what outcome measures are you using to monitor improvement with each session? That's something any of you would like to jump in with?
So I use just a numerical pain scale of 0 to 10. So, you know, I'd ask them what their pain score was when they first came in, but also have a conversation with them around what they hope to achieve so that I can, you know, get an idea of what the patient's goals are. And then that's kind of what we work towards. And the numerical pain scale then gives us an actual measure against, you know, how they felt the first week, how they felt the second week, that type of thing. And then we can look at how they're able to get back to their activities as well. So those would kind of be my, you know, a more tangible measurement and then a more subjective one.
Yep.
Mm-hmm.
For us, we use PhysiTrack links into clinical, so we can send them exercises. So for, you know, as I'm saying, most people will end up with an exercise or two. That's quite handy that you can also add a pain scale if you want. We tend to just use the VAS. Again, it's the 1 to 10. Again, we try and sort of see where do you want to go to. So I always set it, if they're coming back in 2 or 3 weeks, I'll review it every 3 or 4 days if I can. And just it pings onto their phone or app and it'll just say, what's your pain today? How are you getting on with that? If their pain's increasing, I can just drop them a message through that. Dead simple, really quite easy. When they come back for the review, we have things like the easy gait and the easy angle from GMT. So I can measure the strength, see if we're getting strength back in areas, see if their balance is improving. Whatever we're doing, I can just sort of measure it with a Newton scale, which is quite easy. So you can sort of say, well, you only had 30 or 40 Newtons of power this time. You've got, you know, 45 this time. So it's better. And that way you can also see if they're not doing their exercises, which is quite good.
Yeah, indeed. Absolutely. And actually, sort of related, I almost asked a question earlier about the 3-2-1 for the audience out there that don't know what I'm talking about. 3-2-1. It's not me remembering Dusty Bin or anything. It is my Ted Rogers impression. I can't do it. That's my 3-2-1. 5-4-3-2-1. 3-2-1 is we typically, so you can outline or you can signpost to your patients when you see them today. You can treat them 3 times this week, twice next week and 1 the following week. So that gives you a really good parameter to work around to your patients, so you can signpost that. Do you find that typically works for you guys? Are you within those parameters? Are you signing people off after the second one? I don't know. What would you typically say? Sasha, any thoughts on that?
Yeah, I use 3-2-1. I find that doing the 3 sessions in 1 week really accelerates the healing process. And then by the time they reach maybe the second week, the second session, usually we have a couple of weeks gap before the final top-up session, and sometimes they don't even need that. So I feel like putting it into an intensive sort of treatment works well.
Brilliant. Great. Kirsten, I know when we did your presentation last month, you found you were signing people off sooner than that. You typically were treating people within the 4 sessions.
Yeah, I don't tend to do the 3-2-1 purely because I just really struggle to fit that in. My diary is booking up, you know, like I've got no spaces left for this year. So I really struggle to take someone on and then book them in for, you know, for 3 sessions that week. I just don't have the availability. So at the moment, I'm staying on at the end of the day to see my laser patients. And so the once a week works quite well for us. And, I think I just did it to see how it worked. I need something that works for patients, but also works for my diary. And the 30-minute kind of more intense session once a week works really well. And I think it does depend on how long the person's had the problem for. You know, sometimes more chronic issues do need a few more treatment sessions. But, you know, I said to you this week, I had a girl in with a 12-year history of pain and treated her. And after one session, she was sleeping better. She was able to do a full workout without the sharp pain that she's had for years. So not always the case, but I think just base it on the person and go with it. You know, as many as they need, you do it. If they need just 2, like the person in my case study, he just needed 2. That was great. If they need more, then we do that.
Yeah, sure. Yeah, no, that's great. And that, you know, obviously we set out the 3-2-1 as a kind of suggestion when you guys are first taking the laser on, but you know, it's not a color by number piece of equipment. This is, you know, you guys have got the experience and the knowledge, and you know what you're trying to achieve. So you do that within the parameters that you have. Okay, let me just go here for any other questions. Feel free to fill in, anybody, if you'd like to add anything you want to add that you don't think that's been covered. But just got 1 or 2 questions here, I think, coming in.
I'll just dive in on the 3-2-1. I think it depends on what the problem is. Some people need a bit more, some people need a bit less. If we can get people in twice in the first week, I'm pretty happy with that, because then you get an idea if it's going to be a bit more successful for them. Quite a lot of people we only see once a week, just depending on availability for them as well as our diary. But generally we get a lot of resolution quite quickly, and that way we can progress the rehab and start fixing the core problem, which is kind of the key for us.
Brilliant, thank you. Yeah, as I say, I mean, I always refer to the 3-2-1 purely as a kind of, you know,
it's a good guideline. Yeah,
it's a good guideline, but as I say, you know, you guys know what you've got in front of you, you know what you want to try and achieve, and in the main, the laser helps you do that. So that's great. Okay, any other questions coming in? Okay, thank you. 1 or 2 comments. The time response depends. Okay, we've got something here from Roberto. Do you want to jump in, Roberto? Do you want to elaborate on that for us? Always nice to hear your voice.
Yes.
Just to introduce Roberto. Roberto is our man in Italy from Acer Laser. Great support to us. In normal times, those of you with the laser would have met Roberto a couple of times by now, because he comes over to the workshops for us with a colleague, Salvatore, and we always enjoy them coming over, and that's a big part of the support mechanism that we have in place here at Celtic, that we continue to keep you guys upskilled with the modality once you've got it. So sadly, we haven't been able to, we've obviously had to put that on hold this year, but we're hoping to have Roberto and Salvatore and another star guest join us on a webinar in the coming weeks. Yeah, Roberto, jump in. Any comments?
Yeah. No, basically one thing that it's we should keep in mind that I mean the response of the patient, it depends on the metabolic process, which is different from one patient to the other. That's why sometimes, I mean, you need to change even the parameters to get a better response. So sometimes it's difficult to give a clear standard 3-2-1 or 3-2-2, or it depends on the patient. It depends on the response.
Brilliant. Thank you. Great. Okay. There's 1 or 2 comments coming in on the 3-2-1, but pretty much confirming what we were saying, so that's good. What haven't I covered? Any other questions? Oh, Adam, maybe I'll come to you on this one. We did have a question earlier that I scribbled down. Setting for nail surgery healing. Do you use it much for the nail surgery healing?
All the time.
All the time?
All the time. If I can find a way to use a laser, I will use a laser.
Good man.
I don't use it on the day we do the surgery, but we tend to get the person back. What is it? Is it about within 3 days? If I can do within 3 days, perfect. So in our clinic, again, it's good because we've got a lot of people. We tend to have spaces. I don't like to be too full, so I always try and keep space. So it's for us, we can fit them in. So we try and get them back within 3 days, then a week, then 2 weeks after, and generally they're about healed. So at the dressing change within 3 days, we will laser. We'll do it after the week. We'll do it generally if it's not healed, if it's still a bit wet the next time, we'll do it then. But usually, to be honest, it's not bad. We've only ever had to really use it 3 times on a nail surgery, maybe 25% of the time, if I'm being a bit generous with the number. That's probably a bit higher. So yeah, we've had good results, but again, that comes down to changing a few of our other protocols. Sasha recommending Clinicept, which everyone walks away with, and making sure they're doing all the dressings. So we've changed it, but the laser, as I say, is really pretty much half our nail surgery healing time.
Okay, brilliant. Thank you. Anyone want to jump in on that as well? Otherwise, I have got another question from the floor. Actually, I had a question earlier from Leonie. Leonie is one of our users of the laser, just took it on quite recently. Our first pod in Southern Ireland to take it on, so we're delighted with that. Where's Leonie's question? It was around arthritis on the ankle. Any thoughts on that? Any recommendations of how she might treat that best?
What one was that?
Sorry, Adam.
Sorry, I didn't hear you.
Sorry, did you not? Any recommendations? I've got patients with arthritis in the ankle. Any recommendations of how she might go about that with regards to treating?
For me, I don't know if the girls would do different, but there's a foot arthritis setting for trigger points. I would do that with probably the chronic pain. There's also an ankle dislocation, which I don't think a lot of people use quite as much. I find that quite useful for a lot of things, particularly if you've got a sort of slightly forward talus. I find that works quite easy, just to reduce the inflammation response of the talus bashing off the bones around it. We get quite good results there. So I would maybe try the foot arthritis. Use your trigger points for there. It does come up with 15 trigger points. But if it's only the ankle, you can limit it to the ones around the ankle. I think there's 3 there. So you could limit it to that, use your chronic scan phase first, and possibly even do a little bit of inflammation. It's a bit swings and roundabouts, but it does work pretty well.
Okay. I'm just looking to see if anyone else wants to jump in there. Got a couple of other questions. I'm conscious of the time. 1 or 2 people are leaving us, and I completely understand why, but we'll keep going until, if I'm the last man standing talking to myself, I'm happy. I'm quite happy to talk to myself. So we'll keep going, all whilst you guys are happy to answer some questions. Adam, do you add any extra fee for using laser for nail surgery healing?
No, it takes about a minute. I know you can, but to be honest, not for that.
Fair enough.
I'm the same. I don't charge extra for that either. It literally adds no time onto the appointment.
And it's sitting there.
Yeah.
Brilliant. Yeah, absolutely. Yeah. No, fair enough. Good for you. And on that then, the timings of the treatment. I mean, we advertise it as that no treatment takes longer than 10 minutes. The protocols that the machine will offer you, depending on what you're treating, can be as quick as 3 minutes. The average is somewhere in between 6 or 7 minutes. Do you find that the protocol timings, it is as quick as we purport it to be? You would?
Yeah, I can just fit it in.
How that was going to go, so I'm glad you said yes.
I'll let Sasha speak. I speak too much.
I was just saying that we just book people in for short 15-minute appointments, and that works quite well for most things. Yeah.
So coming back to that the whole thing about when you got the repeat treatments and you've got to see that patient again. I won't say 3, 2, 1. I just said it. Whenever you want to see them again, you can kind of fit them in. They're in, and they can, it can be as quick as a 10 minutes, repeat session. So I know you guys are busy, and the additional PPE at the moment is not helping in between patients. But I do have a couple of users that do that. They don't necessarily book them in for a full session for that repeat session. They know what they're coming in for. They'll check them quickly, and any change, what have you, and then it's a quick, potentially 10-minute in and out kind of treatment. I'm sure it's more complex than that for you guys, and you have to, you know, duty of care and so forth. But the treatment isn't a long drawn treatment, certainly after the first one, once you've established what you think you need to do. So it's always good to understand that I'm right in what I say, is that, you know, the treatments can take between 3 and 10 minutes, the protocols, and that typically does work. So it's good to
Although I usually do the 30-minute treatment. You know, I had somebody in yesterday who had pain, and I felt the laser would be good for him. So I just added it into his first treatment use. So we just did a really quick laser session just to see how this goes. If you want to come back, you know, for a full course, then you can do that. So it's really easy to add in what I view as little tasters. So yeah, it works well for that.
Okay, we've got another question from Jenny. Do you guys use this for more chronic conditions? I suppose, do you use it more typically for chronic conditions or acute?
Both, I think.
Both?
Yeah. And it works well for both.
Yeah.
Everything and everything, literally. Yeah.
If in doubt, laser it.
Yeah.
So.
I'm going to use that motto. That's gonna stick.
Personally, get that copyrighted before it's
thanks everyone, really helpful. That's from Penny. Penny's an ASA laser superstar as well.
There was one from Michael.
Sorry?
There was one from Michael about nail based on 2
I missed that.
centimeters.
Oh, thank you. Can you find it? Have you got it there?
Yeah, I was just scrolling up. Yeah. So the nail area, Michael, might be about 2 centimeters by 2 centimeters, but by the time you add your sort of 2 to 3 centimeters around it, it takes you to roughly 10. I would just say for a wound, I tend to just use the minimum setting is 10. So I would always set it to 10 if it's quite a bit smaller, and just run as a 10 centimeters, as long as you're covering the area, moving it around and not staying stagnant. That's the only thing I'd say for a smaller digit or nail.
Brilliant. Thank you, Adam. I completely missed that one. I'm missing there was another question in there. One from Mary. Mary, another ASA laser superstar. Didn't realise you'd snuck in there, Mary. Nice to see you. Quick question, Rielsa. I mean, Mary uses the laser to great success. She's really getting some great success from it, but it looks like she'd like your opinion, guys. Quick question, Rielsa. I have a tiny ulcer on HV. Lateral, I guess that means. HV, lateral, 3 millimeter times 1 millimeter. What settings would you use?
Again, just the wound healing, I would probably set it to sort of the minimum 10 centimeters and go around roughly 10 centimeters around that area. Just try and stimulate as much of the surrounding tissue as well as the wound area as well.
Brilliant. Thank you.
Mary taking it on home visits. I have done that before. It is fun, but trying to make sure the dog doesn't knock it down can always be interesting.
Let us know how that goes, Mary. 1 or 2 people, another more thank yous coming in, which is great. Great, thanks everyone. From Jenny, you're very welcome. Nice to see you.
There was a question.
Did I hear someone? Oh, yeah.
Yeah, I seen there was a question, I don't know who it was from, asking about Lamisil versus Clinisept in nail operation, so I just wanted to answer it if that's okay.
Of course.
Previous to Clinisept, we were all kind of using another antifungal topical product. For me, this gave quite varied results. It had an alcohol-based ingredient, so I found that it dried out the nail quite a bit. And also there was an allergen risk alongside that, so that's why I switched to Clinisept, just for the reasons that I gave in the presentation as well, that it was non-toxic and minimised that allergy risk. So that's why I haven't used Lamisil. I've used Clinisept instead, and it really is a breakthrough product in podiatry, I think. So that's my answer.
And for patients as well, Clinisept is much more affordable. You get a tiny bottle of Lamisil for more than you get the 250 ml Clinisept.
like just to show you the bottles that we have in the clinic. So this is what we use. Prepper's procedure is what we use for day-to-day clinical use. But for retailing wise, there's a 250 bottle here, and then they've recently repackaged to a 100 ml bottle as well. So even if it was just using the 100 mils, that's going to last forever, and they can use it for other things as well. And it's all major podiatry suppliers, just to answer Tim's question as well.
Brilliant, thank you. Lots of thank yous coming in. Thanks everyone for your input and recommendations. Thanks everyone. Cheers, Steve. You're welcome. Thanks everyone.
I just saw something there, Steve. Somebody, Leonie, saying she's reluctant to do a taster at the end of treatments in case it backfires and they feel nothing.
Right, yeah.
I always say to people that, you know, it is just a shorter session. I've yet to find someone who hasn't benefited from that. And if I'm really limited for time, I usually go in with the trigger points, because that's the real kind of punchy treatments. They use a lower hertz, and the lower hertz penetrates deeper, so you get a better effect. If someone has a specific pain point or a specific area that's really tender, generally if you palpate that, it'll hurt them, and then you can use your trigger points on that and palpate it again, and they will have a reduction in pain. So they'll see that at the time of the treatment. It's really unlikely that they'll feel nothing. So I would say just do it, and very often it's almost like an upsell. Here's a couple of trigger points, feel that immediate relief, and then come back for a full treatment later. So I would definitely even just do that.
Yeah, I'd say to Leonie as well, we quite often will add it on. We do have it as a package, so if somebody comes in for a routine treatment and they want to add laser because it's the extra time, we do charge for that. But generally, if somebody comes in and says, oh, I've been getting a bit of pain here, if we've got the time at the end of a treatment, we'll just say, well, let me just do a very basic, if you feel a benefit, give me a phone in a couple of days and we'll book you in. And we just say, it should reduce the pain, but it might only reduce the pain for a day or so. It shouldn't reduce it too much, because we're not able to do probably the full parameter. If we can get a few days, and generally we have a huge uptake of people we do that very short laser on, that book in and come back for a 1 or 2 or 3 laser sessions. Sometimes the full package is 6. So it's if it's sitting there and you've got the time, you might as well do it. That's my advice.
Totally.
Thank you. I didn't realise Jamie had snuck in. Hi, Jamie. Looking forward to my demo next week, Steve. Cheers, Jamie. Absolutely. And Adam has said you'll love it. He's quite right. Great, Jamie. Yeah, looking forward to getting that to you. Be the first in West Wales to take the laser on. Set the standards in your part of the world. So that's one corner of the world we haven't quite yet got to. So thank you, Jamie. We'll get that organised. What else? Great advice from Leonie. Got your thoughts there, Kirsten? Thank you. Great advice. I'll do that. Thank you. Great tips. This is what's really important for our users out there. You know, keep sharing. We've got the laser forum that we go on to. It's a question of sharing, because we all come across different situations all the time. So that's great. Have I missed anything? You guys are keeping me in check where I have missed 1 or 2. Have I missed anything now? Or are we all good?
I'll ask Sasha a question. Don't look too terrified. How long do you get them back for fenestration?
I get them back every 4 to 6 weeks, so that's what I was doing before. And then just really the laser is just the initial sort of treatment, and then after that you're carrying on with your usual fenestration protocol.
Cool.
Okay, Adam, if the client, hi Elena, nice to see you. Adam, if the client wants to book set of laser sessions, what would you tend to charge? That's a question for Kirsten as well, I'm going to say. Sasha, if you'd like to share that with us.
I would say we're slightly cheap, but I don't want to make the excuse it's the part of the world. It's just we had a look around, there was nobody else there, and we set it based on a couple of people with Shockwave. And I didn't think that actually they only see them once or twice a week, maybe once a week. We'll probably see them twice a week. So if it's an additional onto an extra appointment, it's £30. It's £40 for the session, plus we'll charge them the appointment fee, which is £35. Generally, we try and sell laser as a pack of 6, which is £300. Oh God, now you're asking me. I think it's £300. Pretty sure it's £300. I really need my notice board in front of me. I need my notice board in front of me, you know. I don't deal with the money. Once they're done in my room, kick them out. That's why we've got a reception. So yeah, basically, a package works well. If they've got the 6, quite often we'll do 3 or 4. And often we'll just say to them, we'll just keep your last 1 or 2 sessions in your back pocket. And we've even let people transfer it onto the wife or the husband or, you know, their son. Because they've paid for it. And I just kind of think if they do that, quite often somebody else will get recommended and things. So if they buy 6, I don't really care if they use their 6 or their wife takes 1 or 2, they'll use it. And generally it's the word of mouth that comes from that is the real benefit. We've had so many people come in because they've heard of it. And it also helps that we've got the big board, kind of like what's behind Sasha in the waiting room. Everybody sees it when they come in. So yeah. Having the marketing's the key. So having that visible for people is key as well.
Brilliant. Anyone else on that? Kirsten, I know you got your charging structure in place.
Yeah, so we charge 55 for a standalone treatment and 200 for a course of 4. And if after the course of 4 somebody needs more treatments or they would like a follow-up treatment, whether it be, you know, a month or 2 or 6 down the line, then we charge that at £50, which is the same price as, you know, per session for a course. And that works well for us if we're doing it as part of a first treatment. So our first treatment charge, our initial treatment charge is 45. If they have a laser as part of that, then it's 75 for that initial treatment, and that works well for us.